everyone, how are you? In this video, I would like to go over a case where patient presents with a significant root resorption associated with endodontically treated tooth number 9. This is a refer case from outside, and I do not know the full medical and dental history of this area, but I'll be curious to know whether this patient sustained trauma in the anterior maxilla. So now let's go ahead and start looking at the scan with our axial view. As I start from the very inferior portion of the scan and move apically or superiorly to the maxillary arch, here we'll see that tooth number 9 is endodontically treated. And here it's rather evident, as we'll see in other planes as well, there's a large radiolucency causing disruption of the adjacent buccal cortex, and look at the amount of resorption that has occurred, which clearly extends from the root surface of that tooth to the endodontic material, most likely gutta percha in this case. You can also, while the radial density is not clearly distinguishable, you can see there's some evidence of expansion of the buccal cortex. This is better visualized in the sagittal view. Along with that, we see a few foci of highly radiopaque material, most likely representing endodontic material. Now let's look at the sagittal view. As we have already identified the features from the axial plane, we see somewhat irregular root resorption involving the apical third of this tooth number 9. It's not a smooth resorption, but I say that's an irregular root resorption right at the apex. And again, interestingly, there is an expansion of the buccal cortical plate. The plate itself has expanded and significantly thinned, and there's a high probability of this being perforated focally along the buccal area. Let's go ahead and take a look at the corrected coronal view. Besides the evidence of mesial caries, here again we see a well-defined radiolucency causing resorption of this tooth and extending distally to cause the resorption of the lamina dura on tooth number 10 as well. In terms of its superior extension, it's at least, I want to say, 2 millimeter, if not 3 millimeter, 2 to 3 millimeter away from the floor of the nasal cavity. 3D rendering is visualized here. Obviously, there is a large radiolucency with bone loss. But as we look at this axial view once again, I do not see any gross evidence of tooth number 9 being displaced. It's just being resorbed with an irregular pattern. And my differential diagnosis in this case, at the very top, I'm considering apical peritonitis, persistent and chronic apical inflammatory disease, apical peritonitis and apical granuloma type of lesions. Although I have seen these inflammatory change causing the expansion and perforation of the buccal cortex, given its size, but I think we still cannot 100% rule out that there's a possibility of this being some other type of lesion may cause having this mass effect like appearance. So I think the best recommendation is to do a biopsy of this tooth at the time of the extraction, and just to have a definitive diagnosis of this being apical inflammatory lesion. But I hope you found this case interesting, and I'll see you in the next video. Take care, everyone.